Welcome to the Deep Dive, where we unpack complex topics into essential nuggets of knowledge. Today, we're embarking on a crucial deep dive into the very latest clinical practice guidelines for managing varicose veins of the lower extremities.
That's right. And these are truly comprehensive guidelines, published in two parts by the Society for Vascular Surgery, the American Venous Forum, and the American Vein and Lymphatic Society. They synthesize, vast amounts of evidence from systematic reviews and meta-analyses, all rigorously graded using the grade method.
Right. And when you hear us reference a grade or quality of evidence today, just know that a grade 1 recommendation is strong. It's something clinicians should do backed by robust evidence. A grade 2 is more of a suggestion. Quality of evidence A means high certainty, strong studies, while quality of evidence B is moderate certainty. Our mission for you, the specialist clinician, is really to navigate this extensive material, highlight the most important insights, and equip you with a shortcut to being exceptionally well-informed. We'll cover everything from patient evaluation and classification to conservative and pharmacological treatments, various interventional strategies, and even the nuances of managing complications and future research directions. Let's jump in. Evaluation of patients with varicose veins. So to truly get a handle on chronic venous disorders, we first need a common language, right? A way to describe them consistently. And from these guidelines, it seems that a robust classification system is, that essential foundation.
Absolutely. The foundation begins with the 2020 updated Clinical Etiology, Anatomy, and Pathophysiology, or CEAP, classification system. This system is just crucial for standardizing diagnosis and reporting, allowing us to speak the same language globally.
Okay, CEAP, let's break that down.
Right. So the C in CEAP stands for clinical classification. It ranges from C0, meaning no visible or palpable signs of venous disease, all the way through to C6, which denotes an active venous ulcer.
Okay, 0 to 6. What about the steps in between?
Good question. So C1 refers to telangiectasias, spider veins or reticular veins. C2 indicates varicose veins, those dilated, often tortuous veins we typically think of. And when you see C3, that's where edema comes into play.
Right, swelling.
Exactly. And as the numbers progress, they indicate increasing severity. So C4 marks skin changes like pigmentation or eczema, or even more severe conditions like lipodermatosclerosis. That's a hardening and discoloration of the skin, or atrophy blanche, which are these painful white scar-like patches.
And I see here each class can also be noted as symptomatic or asymptomatic.
That's correct. S for symptomatic, A for asymptomatic. And what's particularly useful is the specific identification of AST symptoms. Heaviness, achiness, swelling, throbbing, and itching helps quantify the patient's experience.
ASTC. Got it. So that's the C. What about E, A, and P?
Right. So beyond the clinical signs, CEAP also incorporates etiology, the E, telling us if it's congenital, primary, or secondary, perhaps post-thrombotic. A is for anatomy, specifying if it's superficial, perforator, or deep veins involved. And P is for pathophysiology, detailing if the problem is reflux, obstruction, or maybe both.
Comprehensive.
It is.
Okay.
And complementing CEA, we have the Venous Clinical Severity Score, or VCSS. This offers a quantifiable measure of disease severity and, crucially, response to treatment. It scores parameters like pain, edema, pigmentation, and ulcer characteristics from 0, meaning none, to 3, indicating severe. So it gives you a numerical baseline to track progression or improvement over time.
Okay, that makes sense.
So, to micro-recap this part, the CEAP classification offers that comprehensive diagnostic framework, while the VCSS quantifies severity. Both are really essential for consistent clinical assessment and research.
Okay, building on that understanding of CEAP and VCSS, let's turn to how we actually see what's going on beneath the surface. Duplex ultrasound is our main diagnostic tool here, but its use isn't always straightforward, is it? What are the key distinctions clinicians need to be aware of when thinking about DUS?
That's a great point. Duplex ultrasound scanning plays a pivotal, yet nuanced role. For asymptomatic class 1 patients, so those with just spider veins or reticular veins, the guidelines strongly recommend against routine duplex ultrasound evaluation. This is a grade 1 strong recommendation, quality of evidence B.
Okay, against it, why is that?
Well, the rationale is really twofold. It's typically just a cosmetic problem in these cases, and importantly, prophylactic intervention here doesn't prevent progression to more advanced disease. Crucially, we prioritize preserving the great saphenous vein, the GSV, as a potential conduit for future bypass surgery in coronary or leg arteries. This aligns with the Choosing Wisely initiative, avoiding unnecessary procedures.
Makes sense. But what if that class 1 patient does have symptoms?
Right. So if a class 1 patient is symptomatic, especially with bleeding or severe pain, then duplex ultrasound may be performed just to rule out underlying venous incompetence. But, and this is key, mild symptoms like intermittent itching don't really warrant DUS that could lead to unnecessary ablation.
Got it. So it's reserved for more significant symptoms in C1. What about higher classes?
Now, for symptomatic class 2 all the way up to class 6 patients, duplex ultrasound is absolutely essential. It provides comprehensive mapping of the superficial, perforator, and deep veins. It identifies reflex like axial reflux, which is that uninterrupted backward flow in the main truncal veins or obstruction. And that mapping then guides our intervention.
Okay, essential for C2 to C6 symptomatic patients.
Yes. And what's also critical is that in patients with advanced symptoms, say class 3 to class 6, or even certain class 2 patients with specific indicators like venous claudication or maybe abdominal wall varicosities, well, investigating the iliac veins is warranted. This ensures our superficial venous interventions don't inadvertently impair deep venous return from the limb.
Ah, okay. Looking at proximally.
Exactly. And one final point on DUS. For patients with medial thigh or vulvar varicosities, evaluating for pelvic venous pathology with DUS or other imaging isn't indicated if they have no other symptoms of pelvic venous disease. Direct treatment of the varicose veins themselves is often effective without needing to chase down a potential pelvic origin if the patient isn't otherwise symptomatic from a pelvic standpoint.
Interesting distinction.
So yeah, in summary, duplex ultrasound must be used selectively, judiciously, always guided by the patient's symptoms and their CEAP line of classification, and with careful consideration for preserving that great saphenous vein.
All right, let's test your understanding, listeners, with a Bohr-style question. A 45-year-old female presents with extensive telangiectasias and reticular veins on her medial thigh. She reports only occasional mild itching. She requests a duplex ultrasound to make sure it's nothing serious. Based on the guidelines we just discussed, what is the most appropriate initial recommendation regarding duplex ultrasound and why? Take a moment to consider that. Okay, the answer. Routine duplex ultrasound should not be performed. The rationale is that asymptomatic, or very mildly symptomatic, class 1 disease is typically cosmetic. Prophylactic intervention doesn't prevent progression. And crucially, preserving the great saphenous vein for potential future use is prioritized. Mild symptoms alone just don't warrant the duplex ultrasound in this scenario. 2. Conservative and pharmacological treatments. Now, let's unpack the role of compression therapy. It's such a long-standing tool in our arsenal, it feels almost foundational. But what do the latest guidelines truly say about its primary role, especially for those class 2 veins?
You're right. It's often the first thing people, patients and doctors alike, think of. Compression therapy, primarily through graduated elastic compression stockings, aims to decrease pain and swelling. It works by physically opposing tissue expansion and reducing venous hypertension. However, and this is important, for symptomatic class 2 varicose veins, its role as a primary treatment, well, it lacks sufficient high-quality evidence to really determine its effectiveness. A Cochrane review looked at 13 trials and found that while some studies suggested symptom improvement, they were often subject to bias, and, patient compliance was highly variable due to side effects like itching or irritation.
Right. Getting patients to wear them consistently can be tough.
It really can. So what's truly crucial here, and a key takeaway from the guidelines, is that for symptomatic class 2 patients who are candidates for intervention, the guidelines strongly recommend superficial venous intervention over long-term compression stockings. This is a grade 1 recommendation. Quality of evidence B.
Wow, grade 1 over compression.
Yes. There's simply no rationale for that typical 3-month trial of compression therapy before intervention for these patients, despite the fact that insurance often requires it. In fact, cost analyses, particularly from the UK, suggest that minimally invasive endovenous therapies are actually more cost-effective than indefinite compression therapy.
That's a really important point for practice management and patient counseling. But what about after a procedure? Does compression have a role there?
Yes. Post-procedure compression, that's a different story. Following thermal ablation for saphenous incompetence, whether or not you do a concomitant phlebectomy, the guidelines do suggest compression therapy for a minimum of 1 week, specifically for pain reduction. This is a grade 2 recommendation, quality of evidence B. Compression helps reduce that post-operative bleeding, bruising, edema, and pain.
Okay, so helpful for recovery.
Definitely. Meta-analyses show benefits in pain reduction and earlier return to daily activities, especially after endovenous laser ablation, even if you do phlebectomies at the same time. The recommendation is for a compression dressing greater than 20 millimeters of mercury, maybe with some eccentric pads over the ablation point, for optimal pain reduction.
Good practical tip.
So to micro-recap this bit, compression therapy has limited evidence as a primary standalone treatment for symptomatic varicose veins, but it is beneficial post-procedure for pain management, especially after thermal ablation.
That's a very clear distinction. So if compression isn't the go-to primary treatment, what about pharmaceuticals? Are pills or supplements truly impactful? Or are they more for symptomatic relief when intervention isn't an option or hasn't fully resolved things?
You've hit on the nuance perfectly there. For symptomatic patients who, for whatever reason, are not candidates for intervention, or perhaps they're waiting for intervention, or maybe they have some residual symptoms after intervention. Well, in those cases, the guidelines suggest specific pharmacological treatments can help with vein-related pain, that feeling of leg heaviness, or the sensation of swelling. This is a grade 2 recommendation, quality of evidence B.
Okay, so for specific situations, what kind of drugs are we talking about?
These are generally known as venoactive drugs, or VADs. They aim to improve venous tone, reduce capillary hyperpermeability, and often have some anti-inflammatory properties. Among these, micronized purified flavonoid fraction, or MPFF, and Ruscus extracts stand out with particularly strong evidence in the guidelines.
MPFF and Ruscus extracts.
Yes. MPFF, for instance, has high-quality evidence from large trials, like the RELIEF study, showing significant improvement in leg symptoms, edema, and quality of life in patients with chronic venous disease, including those in Class 2 up to Class 4. Ruscus extracts also show significant improvement in symptoms like leg heaviness, pain, and cramps based on systematic reviews. There are others mentioned too, like horse chestnut extracts and red vine leaf extract, which also show symptomatic benefits.
There's several options.
Several options, yes. But the key takeaway, really, is that while these VADs can offer good symptomatic relief, they are primarily intended for patients who are not undergoing or are awaiting definitive intervention, or perhaps for managing those lingering residual symptoms. They aren't a substitute for intervention when it's indicated.
Right, managing symptoms rather than fixing the underlying problem.
Exactly. So the micro recap here. While venoactive drugs, particularly MPFF and Ruscus extracts, can offer symptomatic relief, they're primarily for patients not undergoing or awaiting intervention or for managing residual symptoms.
Okay, so we've covered classification, the careful use of imaging, and the roles of compression in pharmacological agents. Let's synthesize this first big block of knowledge.
Sounds good. So we've learned that a precise diagnosis using the updated CEAP classification and the VCSS score is really the essential starting point. Duplex ultrasound is invaluable, but critically, it must be used selectively. Unnecessary imaging, especially for asymptomatic Class 1 disease, is discouraged, largely to preserve the great saphenous vein. For symptomatic Class 2 varicose veins, superficial venous intervention is actually recommended over long-term compression stockings based on effectiveness and cost-effectiveness, though post-procedure compression is beneficial for pain relief. And finally, specific pharmacological agents like MPFF and Ruscus extracts show good evidence for improving symptoms, but mainly in select patient populations, those not getting or waiting for procedures or with leftover symptoms.
Excellent summary. Now let's put it into practice with a clinical scenario and board-style question for our listeners. A 68-year-old patient presents with Class 3 symptomatic varicose veins due to primary superficial reflux. They have significant leg heaviness and swelling. However, they are currently not a candidate for intervention due to other comorbidities. What non-invasive options, supported by the evidence we've discussed, could you suggest, and what benefits would you expect? Take a moment to formulate your answer. Okay, the answer. You could reasonably suggest micronized purified flavonoid fraction, or MPFF, or perhaps Ruscus extracts. MPFF, for example, has that high-quality evidence supporting significant improvements in leg symptoms, edema, and quality of life in patients with chronic venous disease, including those with Class 2 up to Class 4 disease. Compression stockings could also be used for symptom relief, but remembering that long-term compliance can be an issue, and critically, it's not a substitute for intervention if the patient eventually does become a candidate. 3. Treatment of varicose veins. All right, now let's dive into the core of management, the interventions themselves.
Let's start with treating the venous tributaries. These are often the visible problem for patients, the ones they complain about most. How do the guidelines approach these?
Right, the tributaries. So for patients with symptomatic telangiectasias and reticular veins, our spider and slightly larger feeder veins, The guidelines strongly recommend sclerotherapy, using either liquid or foam. This is a grade 1 recommendation, quality of evidence B. It's a long-standing, effective treatment where we inject a solution, a sclerosant, to close off the problematic vein. Foam sclerotherapy is often preferred for the larger reticular veins as it displaces blood better.
Sclerotherapy is the mainstay then. Are there alternatives?
Yes. As an alternative, transcutaneous laser treatment is suggested, but typically only if a patient has a specific reason, like a sclerosant allergy, a significant needle phobia, maybe sclerotherapy has failed before, or if the veins are really small, less than a millimeter, maybe with telangiectatic matting. This is a grade 2 recommendation, quality of evidence B laser treatment, like using an ND.YAG pound 64 nanometer laser, can show comparable results, but it might cause more pain during the procedure, though possibly less post-procedure hyperpigmentation.
Okay. Laser is a specific backup. You mentioned foam sclerotherapy. Any nuances there?
Well, one interesting point the guidelines make is a consensus statement. There's currently no clinical evidence that using room air to make the foam is less safe or effective than using a carbon dioxide gas mixture. While some studies suggested maybe fewer minor side effects like chest tightness with CO2, visual disturbances weren't significantly different, and the data is limited, so both methods are currently supported.
Good to know. What about the larger varicose tributaries?
Right, moving to those larger, sometimes bulging varicose tributaries. For symptomatic ones, the guidelines state via consensus statement that treatment should be performed even if the main superficial trunks, like the great saphenous vein, are competent.
Even if the main highway is okay, you still treat the symptomatic side roads.
Exactly. The rationale is clear. Treating these symptomatic veins directly, regardless of axial competence, is effective in reducing pain and improving the patient's quality of life.
Okay. Now, often these tributaries are treated alongside ablation of the main saphenous vein. What about timing? Concomitant versus staged phlebectomy?
That's a common practical question. While treating all the lower extremity varicose veins in one setting, what we call concomitant phlebectomy, along with saphenous vein ablation, is strongly recommended. The actual evidence quality supporting this is low, grade C, mostly non-randomized studies. There's likely a small increase in postoperative pain with the concomitant approach.
More done at once, potentially more initial pain.
Potentially, yes. And what's fascinating is that a large percentage of patients, maybe 50 to 70%, might not even need a subsequent phlebectomy if their symptoms resolve sufficiently after just the saphenous vein ablation alone. And indeed, one study found that a significant chunk, around 64% of patients who were planned for staged interventions, never actually went back for the second procedure.
Interesting. So maybe waiting isn't always a bad idea for some patients.
It suggests a staged approach might be reasonable for many, letting symptoms guide the need for tributary treatment after the main reflux source is addressed.
Okay. Now, this naturally raises the question of recurrence. How do we tackle varicose veins that come back after treatment?
Yes, recurrence is a challenge. For symptomatic recurrent varicosities, the first step, absolutely essential according to a consensus statement, is a thorough clinical evaluation and duplex ultrasound scanning before planning any further treatment. You need to pinpoint the source of the recurrence. Duplex can identify things like persistent reflux in a segment that wasn't fully treated, or maybe a recanalized axial vein, or residual saphenous stumps. Its sensitivity for identifying neovascularization, that's the formation of new, often tortuous little veins after previous treatment, can be a bit limited, though.
So DUS is key to guiding the next step. What are the treatment options based on what you find?
Right. The treatment depends directly on that source. If there's persistent or recurrent reflux of the great saphenous vein or maybe the accessory anterior saphenous vein, you can treat that with either open surgical techniques or endovascular techniques like laser or radiofrequency again, with good outcomes expected. If the recurrence is specifically reflux at the groin, endovenous ablation might work if there's a long enough straight segment of vein stump suitable for the catheter. But if the recurrence is due to that neovascularization phenomenon, then sclerotherapy or phlebectomy targeting those new vessels is the way to go. For persistent or recurrent reflux of the small saphenous vein, often ultrasound-guided foam sclerotherapy is preferred. And if the recurrence stems from residual or newly incompetent perforator veins, well, treatment with both open and endovascular techniques might be used, depending on experience, patient choice, and what's available.
Okay, tailored approach based on the DUS findings. Now, speaking of perforators, what about ablating incompetent perforating veins during the initial treatment?
That's another specific point addressed. For patients with varicose veins, CEAP class 2, who have significant symptomatic axial reflux of the great saphenous vein or small saphenous vein, The guidelines actually recommend against treating incompetent perforating veins concomitantly with the initial ablation of the saphenous veins. This is a grade 1 recommendation, quality of evidence B.
Recommend against treating them at the same time. Why?
The rationale is that most incompetent perforator veins actually regress, they close down on their own, after the main superficial truncal vein reflex is corrected by ablation. So treating them concomitantly might just increase postoperative pain without providing significant additional benefit in many cases. It's worth noting, though, that sometimes, less commonly, isolated reflux from perforators can be the primary source of varicose veins, but typically not when there's significant saphenous reflux present.
Okay, that's a very practical guideline. Let's try to connect all these treatment specifics back to the bigger picture.
Right. So we've seen that for the smaller telangiectasias and reticular veins, sclerotherapy is the primary recommendation, with laser as a targeted alternative. For symptomatic varicose tributaries, treatment is indicated even if the main saphenous trunks seem okay, and the decision about doing it concomitantly with saphenous ablation versus staging it involves weighing potential patient satisfaction against maybe slightly more initial pain. Recurrent varicosities, a common issue, absolutely require careful duplex ultrasound mapping to guide specific interventions based on why they've recurred. Is it residual vein, neovascularization, perforators? And finally, the guidelines strongly advise against routine concomitant ablation of incompetent perforating veins during that initial saphenous vein procedure for class 2 disease, emphasizing that these often resolve once the main reflux source is dealt with.
Excellent synthesis. Okay, here's another clinical scenario and board-style question for you listeners. A 55-year-old male undergoes successful endovenous laser ablation of his right great saphenous vein for symptomatic class 2 varicosities. 6 months later, he presents with new symptomatic varicosities in the same leg, specifically clustered around the medial malleolus. A duplex ultrasound reveals new clusters of small, tortuous veins, but no clear residual or recurrent saphenous reflux. What is the likely cause of this recurrence, and what treatment approach is indicated? Take a moment to think it through. All right, the answer. The likely cause here is neovascularization, those new, small, tortuous veins forming. For symptomatic recurrent varicosities due to neovascularization, the guidelines indicate that sclerotherapy or phlebectomy should be performed, targeting those new vessels directly. Performing the new duplex ultrasound was the correct first step to identify this specific source of recurrence. 4. Management of complications and special considerations. Okay, moving on. Complications are, unfortunately, always a potential concern with any procedure. Let's unpack the latest on managing post-ablation thrombotic events. Here, the terminology has even changed. And what are the new guidelines for screening?
Yes, that's an important update. We now use the term ablation-related thrombus extension, or RT. It's a broader term intended to encompass all forms of junctional thrombus extension that might occur after any ablation modality. So, thermal, like laser or F, but also foam sclerotherapy, mechanicochemical ablation, and cyanoacrylate glue. This replaces the older term endovenous heat-induced thrombosis, or EHATE, which is obviously specific to heat-based methods. RT is classified into class 1 to class 4 based on how far the thrombus extends into the deep venous lumen, with class 1 and likely class 2 generally considered to have minimal clinical relevance.
RT, got it. So with this new understanding, what are the guidelines around post-procedure duplex scanning to look for? Do we scan everyone?
Good question. The guidelines are actually quite specific here, trying to balance detection with avoiding unnecessary scans. They strongly recommend against routine, early post-procedural duplex ultrasound in average risk, asymptomatic patients following thermal ablation. This is a grade 1 recommendation, quality of evidence B. The rationale is that the actual incidence of significant R2, deep vein thrombosis, or pulmonary embolism is low, somewhere in the 1.3% to 1.7% range, making routine screening just not cost-effective in this group.
Okay, so no routine scan after thermal ablation if the patient is average risk and feels fine. What about non-thermal methods or higher risk patients?
Right, different scenarios. Routine early post-procedural duplex ultrasound may be performed in average risk, asymptomatic patients following non-thermal ablation like glue or MOCA. This is a consensus statement, suggesting less certainty but allowing for it. However, and this is critical, early duplex ultrasound should be performed in high-risk asymptomatic patients following either thermal or non-thermal saphenous ablation. Again, a consensus statement.
What constitutes high risk here?
High-risk factors would include things like a previous history of DVT or PE, known hypercoagulable states, active cancer, significant obesity, or recent major surgery, trauma, or immobility. And importantly, for any patient who is symptomatic following thermal or non-thermal ablation, meaning they have concerning leg pain, swelling, shortness of breath, we strongly recommend early duplex ultrasound to specifically exclude RTE or DVT. That's a grade 1 recommendation. Quality of evidence, high certainty there.
Very clear guidance based on risk and symptoms. What about preventing these clots? Thromboprophylaxis.
The guidelines state that routine risk stratification should always be performed to assess the need for periprocedural thromboprophylaxis, a consensus statement. While there's a lot of variability in practice and study results, some randomized trials have shown a reduction in DVT risk with pharmacological prophylaxis. However, the optimal drugs, the right dose, and the ideal duration of prophylaxis, those remain areas for future research.
Okay, shifting gears slightly. What about managing acute bleeding from varicose veins? That can be quite traumatic.
It certainly can be. For acute bleeding, the initial management, according to a consensus statement, should involve immediate leg elevation, direct compression over the bleeding point, and often sclerotherapy can be very effective right then and there. This should be tried before considering suture ligation in the acute setting. And crucially, prompt referral to a venous specialist is vital.
So stop the bleeding first, then refer. What next?
Right. Once the acute bleeding is controlled, it's essential to perform a thorough evaluation for the underlying superficial venous incompetence, and then proceed with appropriate intervention, ablation, phlebectomy, etc., to control the venous hypertension and significantly reduce the risk of recurrent hemorrhage. The evidence really suggests that fatal hemorrhage often occurs after a previous untreated bleeding episode. Intervention clearly reduces recurrence. Sclerotherapy works well for smaller bleeding veins, while options like high ligation, stripping, or phlebectomy might be needed for larger ones.
Okay, definitive treatment is key to prevent recurrence.
Yeah.
Lastly, in this section, what about superficial venous aneurysms?
Yes, those focal dilations of a saphenous vein. They're typically defined as measuring 20 millimeters or larger for the great saphenous vein, or 15 millimeters or larger for the small saphenous vein, or just a diameter that's 3 times the average saphenous diameter nearby. For treatment, the guidelines suggest, via consensus statement, that patients with symptomatic thrombose or particularly large aneurysms, say, greater than 3 centimeters are best treated with surgical excision. However, for asymptomatic non-thrombosed aneurysms located more distally, specifically greater than 3 centimeters away from the saphenofemoral junction, endovenous ablation alone can be performed. In these cases, thromboprophylaxis is advised alongside the ablation to reduce VTE risk. But it's important to note that the current evidence is pretty limited for using endovenous ablation on very large or very proximal aneurysms close to the junction. Surgery might still be preferred there.
Okay, so size, symptoms, and location guide the approach for aneurysms. Let's quickly recap this section on complications and special considerations.
Sure. We've clarified the updated terminology of RT for post-ablation thrombotic events, replacing E-height. We learned that routine post-procedure duplex ultrasound is generally discouraged for average-risk asymptomatic patients after thermal ablation due to low incidence and cost factors, but it's definitely indicated for high-risk patients or anyone who becomes symptomatic. For acute bleeding, immediate first aid measures plus sclerotherapy should be followed by definitive intervention to prevent recurrence. And finally, the management of superficial venous aneurysms depends on their size, symptoms, and location, guiding the choice between surgical excision and endovenous ablation, acknowledging the limitations of ablation for very large or proximal ones.
Great. Let's consider a final clinical scenario and board-style question for this section. A 72-year-old male with a known history of deep vein thrombosis presents 2 days after undergoing endovenous laser ablation of his left great saphenous vein. He reports feeling fine and is asymptomatic. Based on the guidelines, what is the most appropriate next step in his management? Take a moment to formulate your response. Okay, the answer here. An early duplex ultrasound should be performed. Why? Because he's a high-risk patient due to his previous history of deep vein thrombosis. Even though he is asymptomatic following thermal saphenous ablation, the guidelines recommend early duplex ultrasound in this high-risk group to proactively screen for and exclude ablation-related thrombus extension, RTE, or deep vein thrombosis. Future research. Finally, let's briefly touch on the frontiers of this field. It sounds like even with these incredibly detailed guidelines, there are still significant knowledge gaps and areas where more research is needed.
Oh, absolutely. Despite the extensive detail, the guidelines themselves highlight significant gaps, areas that are really ripe for future research. It shows the field is still evolving.
What are some of the key areas they identified?
Well, some of the top recommended topics include things like more head-to-head comparative studies of thermal versus non-thermal ablations, looking at long-term outcomes and maybe cost-effectiveness. Also, really pinning down which patients truly need periprocedural thrombosis prophylaxis and defining the optimal drug should be Low molecular weight heparin or maybe direct oral anticoagulants. What's the right dose and for how long? That's a big area.
Yeah, that prophylaxis question comes up a lot. Anything else?
Yes, definitely. They call for clinical trials to properly evaluate the efficacy and cost effectiveness of just using 20 to 30 millimeter of mercury compression stockings versus going straight to venous ablation as the initial treatment for patients with class 2 disease. That comparison needs more rigorous data. Also, figuring out the best treatment options for lower extremity and vulvar varicose vein tributaries, comparing things like miniflebectomies versus foam sclerotherapy directly. And importantly, gathering more robust long-term outcomes data after ablation of the small saphenous vein and the accessory anterior great saphenous vein. We need to know how durable these treatments are over many years. This ongoing inquiry is just essential to keep refining our practice.
It really highlights that evidence-based medicine is a continuous process.
Exactly.
Well, this has been a truly deep dive into the intricate world of varicose vein management, drawing insights directly from the most current evidence-based clinical practice guidelines.
It really has, and the continuous evolution of evidence in phlebology just demands our commitment as clinicians to rigorous, patient-centered practice. Understanding these guidelines, knowing their strengths, but also recognizing the identified gaps, really empowers us to provide the most informed care possible, translating that robust evidence into better outcomes for our patients.
Absolutely. And as clinicians, you're constantly balancing that art of individual patient care with the science of these evidence-based guidelines. Makes you wonder, doesn't it? How might these guidelines continue to evolve as we gather more long-term data, especially on some of the newer, minimally invasive techniques? And how will patient preferences continue to shape the next generation of recommendations? We encourage you, our listeners, to consider how these nuanced guidelines might influence or perhaps change your current practice, or maybe spark further questions in your own clinical work. Thank you for joining us on The Deep Dive.